So neuroendocrine tumors, for the most part, express somatostatin receptors. At least well-differentiated neuroendocrine tumors tend to. And peptide receptor radiotherapy is basically a somatostatin analog that's attached to a radioactive isotope. The somatostatin analog is a peptide. The somatostatin receptor is the receptor on the tumor cell. So basically, it enables delivery of radiation directly to the receptor and thence to the tumor cell. So in oncology, we often rely on something called RECIST imaging for assessment of response. RECIST is basically the sum of target lesions, and a partial response is considered a 30% shrinkage in sum of lesions in one dimension, which roughly translates to shrinkage by about half in 2 dimensions. So that would be considered a significant radiographic response. How often does that happen with PRRT? Well, it depends on the trial that you look at the tumor type. On the NETTER-1 study, which was the randomized phase 3 trial in small intestinal neuroendocrine tumors, the partial response rate was 18%, meaning 18 out of 100 patients had a significant tumor shrinkage. Of course, many more had lesser degree of shrinkage or disease stabilization. In other studies from Europe, there's suggestion that pancreatic neuroendocrine tumors probably have a higher response rate, somewhere in the 20 to 30% range. It probably depends on the line of treatment. If you treat earlier, you're likely to get a higher response. If you treat as a later line of treatment, it's likely to be a lower response. But the bottom line is ballpark. You should expect major tumor shrinkage in about 20% of cases, stable disease or minor shrinkage in the majority of cases, and then just continued growth, probably in another 15, 20% of cases. So a normal cycle is once every 8 weeks. So a standard course of PRRT of Lutathera is once every 8 weeks for 4 treatments. The infusion itself, runs over about 30 minutes, but with amino acids, we're talking about from start to finish on a day, about, I'd say, 5-6 hours. As far as short-term side effects, there is some nausea occasionally with each treatment. That's a lot less if compounded amino acids, arginine and lysine, are used. And I think the vast majority of institutions in the US nowadays are using compounded amino acids. So generally the nausea is not severe. Tiredness, often several weeks after treatment. Patients have decrease in blood counts. Those tend to increase by the time they come in for their next cycle, each 8 weeks. But occasionally the low blood counts can be persistent. The biggest risk is in the long term is long-term bone marrow damage. And about 2 to 3% of patients will have either myelodysplastic syndrome, which is a pre-leukemic condition that's quite dangerous, or acute leukemia. That's probably the most serious side effect of the treatment. Fortunately, it's relatively uncommon, 2 to 3%, but obviously an important one. So prophylactically, we often give Zofran. We often prescribe Compazine after treatment, which is a nausea medicine. Patients can also take Zofran as needed, sometimes steroids. I should point out also patients who are prone to bowel obstruction, patients who have a lot of disease in their peritoneum, mesentery. We have seen some cases of bowel obstruction, which can start with abdominal pain and continue into nausea, vomiting. So that's something that we're actually about to publish some data on. But for patients with a lot of disease in the mesentery and peritoneum, it probably represents a risk. So we see patients prior to each PRRT treatment, meaning once every 8 weeks, unless there are problems. And the scans we generally do about 4 to 8 weeks after completion of treatment. That's a good question. So the gallium-68, or any somatostatin receptor imaging, but these days it's mostly gallium-68, should be done prior to PRRT to establish that all tumors express somatostatin receptors. And it really is important that your doctor establish that it's all tumors have strong somatostatin receptor expression. Plus cross-sectional imaging, like a contrasted CT scan or MRI, We tend to subsequently follow up with repeat cross-sectional anatomic imaging like CT scan or MRI to assess response. We rarely do repeat gallium imaging, but that being said, some people do advocate repeating the gallium imaging after the PRRT. So there is some controversy over the value of that. Rarely there are patients whose tumors are just seem much better on the gallium. They may have mostly bone disease or peritoneal disease that you just can't see well on the CT scan or an MRI. And in that case, you can continue following with gallium. But for the most part, we're talking about CT or MRI. That's a good question. Typically, we complete the entire course of 4 cycles. The cycle is given once every 8 weeks, and then we repeat scans about 6 to 8 weeks later. At least that's what we generally do for most relatively unaggressive tumors. For more aggressive tumors, we'll often check in the midpoint after 2 cycles before the 3rd cycle. But the little bit of a caveat is that you can sometimes get a little bit of an early progression. It's called pseudoprogression in mid-treatment, which is one reason why we don't routinely scan in the midst of the cycles of treatment. Of course, if patients experience significant change in status, progression of symptoms, significant worsening in labs, that would be a good reason to scan early. You can get delayed responses with PRRT. So it's not that uncommon, for example, for the first scan to show stable disease, sometimes even the first scan to show slight progression, and then subsequent scans to show some response. I mean, usually by the first repeat scan, you'll know if disease is at least stabilized. But, the maximum response can be quite long after completion of treatment. Well, that really depends on what they've had before and how long it is until they progress. But it's not going to work forever. The average time to progression is several years, at least with small bowel neuroendocrine tumors. But at some point, patients do progress on PRRT, and then you have to go through the other treatment options. So a single round consists typically of four treatments. There's no clear answer as to what the lifetime maximum is. Conventionally, people feel that 8 is about a lifetime maximum based on, for example, kidney and bone marrow exposure, but whether that's really the case is hard to say. To be considered for more treatment, we'd like to see at least a year of benefit, meaning at least disease stabilization for a year.